All right, future nurses. If you're tackling peds right now, you are in exactly the right place. Today, we're going to zero in on 4 obstructive congenital heart defects. These are the ones you've absolutely got to know, not just for your exams, but for your future patients.
Okay, so let's jump right in. What exactly are we talking about when we say obstructive disorders? Well, at their core, it's pretty simple. They're a physical blockage. The easiest way to think about them is like a plumbing problem inside the heart, a kink or a clog that's stopping blood from flowing where it's supposed to go.
So here's our game plan for today. We're going to treat each one of these conditions like a case file. We'll break down the must-know assessments and the key interventions. All the stuff you need to know not just to pass a test, but for that moment you're standing right at the bedside.
Okay, so we've got the basic idea down. Something is blocked. But where can these blockages happen, and what does that actually mean for the patient? Let's crack open our first case file and find out.
First step, coarctation of the aorta. Yeah, it sounds like a mouthful, but the concept is actually pretty straightforward. It's just a critical narrowing. That's what coarctation means. In the aorta, you know, the body's superhighway for blood.
Seriously, the best way to picture this is a kink in a garden hose. You know how the water pressure builds up like crazy behind the kink and then just trickles out the other end? That is exactly what's happening here. The blood flow, especially to the lower half of the body, gets totally choked off.
So, when you walk into that patient's room, what are you looking for? Because of that kink, you're going to see some really specific things. The pressure builds up before the blockage, so you'll get high blood pressure in the arms, but after it, the pressure just plummets. That means low PP and weak, maybe even absent pulses in the legs. That difference, that's everything. It's your #1 clue.
And here it is, the number you have to commit to memory. When you do that 4-point blood pressure check, if you see a difference greater than 20 millimeters of mercury between the upper and lower extremities, boom. That is the classic textbook sign. It's a huge flashing red light for coarctation. Okay, so what do we do about it? Well, after the docs go in and do a balloon dilation or place a stent, our job kicks into high gear. We're on high alert, watching for bleeding, checking those pulses constantly. And remember, that little heart has been working overtime against that blockage, so a lot of these kids are in heart failure. We'll be managing that probably with meds like digoxin. And of course, there's the teaching, making sure the family knows all about preventing endocarditis, which is a big risk for these patients.
All right, let's move on. Case file number 2. This time, the problem isn't with the pipe itself, like the aorta. Nope. Now we're talking about the doors, the heart valves. We're looking at aortic and pulmonary stenosis. And stenosis just means that these valves are stiff, they're stubborn, and they refuse to open up all the way.
Now, how do you keep them straight? It's all about location, location, location. Which side of the heart are we on? Aortic stenosis, that's a left side problem. It's blocking oxygen-rich blood from getting out to the rest of the body. Pulmonary stenosis, that's a right side problem. It's blocking oxygen-poor blood from getting to the lungs. So just think, left side body problem, right side lung problem. Simple as that.
What's kind of wild is that even though they're on different sides of the heart, the symptoms look a lot alike. I mean, it makes sense, right? In both cases, the heart is struggling, working way harder to shove blood through a tiny little opening. That's why you see fatigue, shortness of breath, and all that turbulent blood forcing its way through. That's the heart murmur you're going to hear with your stethoscope. And the fix? Well, it's also pretty similar for both. They'll often do something called a balloon valvulopathy. It's just what it sounds like. They go in with a catheter and literally use a balloon to stretch that sticky valve open. Now, for the really severe cases, especially in newborns, you'll see them use a medication called prostaglandin E. This is a big one. It's a temporary fix that keeps a special blood vessel from fetal life open, creating a little detour for the blood until they can get to surgery. Okay, on to our last case file. And I'll be honest, this is the most critical one we're going to talk about. We're not just talking about a narrowing anymore. This is a complete and total dead end. The road to the lungs is just closed.
Yeah, let me say that again so it really sinks in. This is not like stenosis where the door is just hard to open. In pulmonary atresia, there is no door. The valve is either totally sealed shut or it just didn't form right in the first place. There is literally no way for blood to get from the right side of the heart to the lungs.
So what does that mean for your assessment? Well, if no blood can get to the lungs to pick up oxygen, you're going to see deep, deep hypoxia. And the sign you need to burn into your brain is this: severe cyanosis right at birth. The baby will be blue. This is a 5-alarm fire, a true cardiac emergency.
So how do we handle this emergency? It all comes down to one medication, prostaglandin E, PGE. This stuff is a literal lifeline. Its only job is to force that fetal blood vessel, the ductus arteriosus, to stay open. That little vessel becomes the only, and I mean only, detour for blood to sneak its way to the lungs. It's the only thing keeping this baby alive long enough to get to the OR.
And this really says it all, doesn't it? If that PDA closes, there is zero blood flow to the lungs. Game over. So that continuous PGE drip, it's not just a medication. It's the baby's entire pulmonary circulation in an IV bag.
Whew, okay, that was a lot, I know. So let's pull it all together. Let's synthesize this down into your nursing playbook, the high-yield stuff you absolutely have to know.
This table right here, this is your cheat sheet. This is what you'll run through in your head at 3 a.m. during clinicals. See that huge blood pressure difference? Your brain should scream coarctation. Hear a murmur with a tired kid? You're thinking stenosis. But see a blue newborn? Your first thought better be pulmonary atresia. Get the PGE. Seriously, screenshot this. It's perfect for that last-minute cram session before an exam.
So at the end of the day, what's the big picture? It's all about being prepared. It's about you being the nurse who catches those subtle signs early, the one who knows exactly which assessment to do next and can anticipate what needs to happen. That's what changes outcomes. Your job is to take all this information we just talked about and bring it to life at the bedside, and you can absolutely do it. You've got this.